Okay, so thank you, Dr. Stiff, for the kind introduction and welcome all of you. So, over the next 15-20 minutes, I will give you an update on the new drug treatment options in lymphoma. So, the topic is very specific, is drug treatment, because there are other new treatments also in lymphoma, which some of them have already been addressed, including transplant and CAR T. So I will talk about Hodgkin lymphoma first, and then second non-Hodgkin, and also include chronic lymphocytic leukemia, because CLL has many features similar to the treatment of non-Hodgkin's lymphoma, and I do see at least 3 or 4 patients in the audience who have interest in knowing about CLL. So in the morning, you already heard a lot about immunotherapy, and many of the drugs I am going to talk are based on immunotherapy principles. So I thought it's a good idea for the next 2-3 minutes I will spend on the mechanisms of immunotherapy, because that can explain the wave by which many of these new drugs are working, not only in lymphoma but also the other diseases you heard about. So all immunotherapy mechanisms you can put into these 4 different groups, because immunotherapy means you are harnessing the body's ability to kill cancer cells. So first, antibody therapy. You heard a lot about it. In simple terms, antibody means a protein you pick up on the tumor cell and make a protein against that tumor protein. So the first example was Rituxan. That was the first monoclonal antibody that was approved in this country for any cancer in 1997, and that was for lymphoma. And this is the cancer cell. This is the antibody that comes and attaches to the cancer cell and kills it in many different ways. You can also attach radiation or radioisotope to the antibody, or a drug like Dr. Jakubowiak has explained. You can attach it so that it will be delivered right to the cancer cell. We also have now antibodies which attach to the cancer cell, and by attaching to T cells, they can draw T cell to the site so that it will help kill it even more. They are called bispecific antibodies. An example is blinatumomab, which is already approved for leukemia, and we are using it as a clinical trial in lymphomas. The second is cellular immunotherapy, that is using cells to do the immuno-based treatment. We all have these cells, T cells, floating around in the blood, and T cells are expected to eliminate disease cells. That's their purpose. They target disease cells and eliminate them, and they should be able to eliminate every cancer cell also, because cancer cells are foreign to our body. But unfortunately, they cannot do that, because cancer cells are very smart. They come up with mechanisms by which they can avoid attack by the T cells. And this is important to know, because some of the new drugs are based on that principle. And one way is, of course, to put in a new receptor instead of a natural receptor. You can put in a synthetic receptor on the surface of the T cell, so that it will be able to recognize and kill the cancer cell. And that's the principle of the CAR T therapy you heard. The third group, checkpoint inhibitors, you already heard that term, is very fascinating. In fact, many of the new drugs are based on this principle. So what happens is, cancer cells, as I said, they are smart. They can put brakes on the T cell, so that the T cell is not able to do its job. So this, for example, is a brake where the T cells are attached, so that T cell cannot attack through the receptor. So the drug, the checkpoint inhibitor, what it does is it blocks this brake, so that the T cell is released and it will be able to attach to the receptor and kill the cancer cell. So this is what is called checkpoint inhibitor. So let's talk about the new drugs in Hodgkin lymphoma. One is brentuximab vedotin, or Adcertis, that's the other name. And this was the first monoclonal antibody that was approved for Hodgkin lymphoma. The second is nivolumab, and third is pembrolizumab. As you can see, the names become more and more complicated as it goes on. So these two are based on checkpoint inhibitor principle. They are classic checkpoint inhibitors. All these three are approved by FDA for treatment of Hodgkin lymphoma that has come back after standard treatment. More recently, just a few months back, this drug, the first one, was approved for treatment of Hodgkin's as first line, which is the first time all these decades of treatment of Hodgkin's lymphoma with radiation and chemotherapy, this is the first time a monoclonal antibody is now allowed to be used in conjunction with chemotherapy for Hodgkin lymphoma. And that was based on this study, which was just 3-4 months back published. So the classic regimen we used was ABVD, a combination of 4 different drugs, and the B is bleomycin, and that was replaced by this new drug, the antibody. What happened was, if you look at the results, there was an increase by 5% of the progression-free survival, which means the time to take the disease to progress. So which means it clearly benefits the patients. Now this study is only 2 years in terms of monitoring or progression, but certainly it is showing that for the first time antibody added to chemotherapy in Hodgkin's lymphoma works. So this was FDA approved just recently. Non-Hodgkin's lymphoma, there is much more than what I just talked about Hodgkin's in terms of number of drugs. If you look at the survival of patients with follicular lymphoma, low-grade non-Hodgkin's lymphoma, CHOP is a typical chemotherapy regimen we use. Compared to that, as these lines go up, the patients live more. That is what it means, the survival curve. So when an antibody, monoclonal antibody, was added to chemotherapy, you can see there's a significant improvement in the survival. Now this is combination of multiple studies clearly showing that the efficacy of monoclonal antibody when combined to chemotherapy is seen across the studies. So it's not only the antibody, but also some of the new drugs, which I'm going to talk about in the next few minutes, have contributed to this improvement. So let us look at some of the so-called newer drugs in lymphoma, non-Hodgkin's lymphoma. Rituximab is familiar to many of you because it is not only treatment for cancer, but also many non-cancer diseases like rheumatoid arthritis. It is FDA approved. Rituximab, as I said, was the first monoclonal antibody for any cancer approved in this country in 1997. And subsequently, of course, new rituximab or new monoclonal antibodies targeting the same protein came. One is called obinutuzumab or Gazyva, which is being used more and more in place of rituximab in certain diseases now. Ibrutinib is the other drug. It's an oral agent. It's not a monoclonal antibody. It targets the cancer cell by blocking one of the pathways which the cancer cells depend on for the survival. So it's specifically blocking the target, which is called BTK or Bruton tyrosine kinase pathway. Acalabrutinib is a modified version of ibrutinib. It blocks the same pathway and it has some advantage. It's also oral, but it has some advantage, especially in terms of side effects compared to ibrutinib. It's also FDA approved. Idelalisib, again another FDA approved drug for certain kinds of non-Hodgkin's lymphoma. It's oral, and the newer form of the same drug, because idelalisib blocks another pathway of the cancer cell called PI3 kinase pathway. And this is also a drug that blocks the same pathway, PI3 kinase, but it has some advantage in terms of side effects. On the other hand, this is oral, this is IV, intravenous, so you have to be going to the clinic to get it, whereas this one you can take it at home. Lenalidomide is a drug you already heard. Dr. Jakubowiak and Dr. Khan, both of them have mentioned it. It is most extensively used in multiple myeloma, but it is also very effective in certain types of lymphoma and is FDA approved at least in one type of lymphoma, the mantle cell lymphoma. So these are some of the new agents which are already FDA approved and already in the market. Let's look at chronic lymphatic leukemia. Rituximab is approved in combination with chemotherapy, it's a standard. Obinutuzumab, I mentioned, is a newer form of rituximab targeting the same CD20 protein on the CLL cells. Ofatumumab is another monoclonal antibody, same target. So all these three drugs have the same CD20 as a target. They are all monoclonal antibodies. There are some advantages of the newer ones compared to rituximab in terms of how it kills the cancer cells. Ibrutinib, which I mentioned along with the drugs for non-Hodgkin lymphoma, oral agent, blocks the pathway called BTK, is approved for CLL. Idelalisib, again, the PI3 kinase inhibitor, is approved for CLL. And finally, venetoclax, again an oral agent targeting something totally different from what we talked about. It targets BCL2, which is a protein that inhibits apoptosis or programmed cell death by normal death. So if it inhibits, naturally, the cells accumulate. That's a principle, or that's what happens in CLL, and this inhibits BCL2. Now, we have seen a list of drugs, and the question will be, which one is best for me? Well, there are various factors that will influence that decision as to what is the best drug among these for your disease. One may be the characteristics of the tumor cell. For example, in CLL, like lymphomas or even multiple myeloma, MDS, the abnormalities in the chromosomes are very important factors that influence the selection of drug as well as the response to drug. For example, in CLL, these are some of the chromosome abnormalities you can see in patients. In fact, the 17p deletion, which corresponds to what is called p53 deletion. p53 is a tumor suppressor gene. 17p deletion, patients who have CLL with 17p deletion, their outcome is unfavorable. If you look at the progression, the rate of progression of CLL, this line represents patients who have 17p deletion. As you can see, they progress very quickly. So going back to the drugs I showed you, the drug ibrutinib and venetoclax are very effective in patients with 17p deletion. In fact, both drugs are approved for those patients with 17p deletion, and ibrutinib is also approved for first-line treatment of those patients. So I think that is one example of how one should be selecting these agents for a particular patient. Then comes the question, can we avoid chemotherapy as a whole? Because historically, for chronic lymphocytic leukemia, the chemotherapy regimen that was used was FCR, is a classic regimen, combination of 3 drugs, fludarabine, cyclophosphamide, and rituximab. Chemotherapy has side effects, short-term and long-term, and now we have non-chemotherapy agents. Can we avoid chemotherapy as a whole? Well, one of the recent studies that indicated that it's probably possible is this. That is, this is a study where they compared the standard chemotherapy for CLL, bendamustine or Trianda, in combination with rituximab, compared it to venetoclax, the new agent BCL2 inhibitor, along with rituximab. And this was used in patients with relapsed refractory CLL. And what you can see here is patients who received VR, which is venetoclax and rituximab, they had significant benefit compared to patients who received a standard chemotherapy combination in terms of the time it take to progress or the disease to progress. So that's a hint that some of these novel agents may be able to be used in situations like this, where we may be able to avoid use of chemotherapy as a whole. Next point is how long should I stay on this drug? This is a very common question that is asked, because we have all these fancy drugs, many of them, especially the oral drugs. Most of the new oral drugs, when you prescribe it, the recommendation is, yeah, you will take it as long as you respond to it and as long as you tolerate it. Unless you develop an unacceptable toxicity or the disease progress, you continue. That's the way FDA approves it also. But I don't think anyone wants to be told that you have to be on this pill for the rest of your life. So that's one. Plus, these are very costly drugs. I'm sure you all know these new drugs are very costly. So then the question is there a definite period? Is there a way by which we can say, okay, you will be on the pill for a year? I don't think we have the answer in CLL or lymphoma, but just to tell a story, there is another disease, chronic myeloid leukemia, which I don't think is discussed today. But chronic myeloid leukemia is a disease where 15-20 years back, for the first time, we had this new pill called Gleevec. And that was a dramatic change in the way we treat those patients at that time. But when we prescribe it, we will tell the patient, you will be taking it for the rest of your life unless the disease comes back or unless you develop a very bad side effect you can't tolerate, you will be continuing. So that was going on until more recently. I myself have patients who have stopped it for 5 or 6 years without any evidence of disease. And finally, FDA approved in the last year that if a patient with chronic myeloid leukemia has taken a drug for a period of 3 years and have achieved a remission status by molecular studies, a particular log reduction in the transcript, you can stop it. So I think the point I'm saying is it is possible with some of these new agents in CLL and lymphoma that may be possible too. And one of the hint that it is possible is this study where they combined these two new agents, ibrutinib and venetoclax. And first they gave ibrutinib alone, and then they added venetoclax and continued it 3 months, 6 months, 9 months, 12 months. So in a year, with 9 months of combination of the two, there was no evidence of disease. This green bar indicates MRD negative. You already heard the term MRD from the previous talk. MRD means minimum residual disease. That means MRD negativity means with all the tests we have now, the most sensitive test like PCR, we cannot find any evidence of disease. That is MRD negative. So combination of these two pills for 9 months, they can't find any evidence of disease. So I think this is very fascinating. It is possible that if we are able to maintain that for a period, we may be able to stop the medication and the patient may be cured. We don't know that. We also don't know what are the toxicities and side effects of such combination. But at least this is very encouraging. Clinical trials, I can't emphasize more than that because all these developments happen because of clinical trials. Just an example is a drug called duvelisib, which is going to be FDA approved soon. It's already submitted. It is, as the name indicates, dual mechanism. It not only kills the cancer cell, but also makes changes in the environment in which the cancer cell flourishes, the so-called microenvironment. So in both ways, it is affecting, influencing the cancer cell. And so there are a lot of other drugs like this in the pipeline that is being developed, and there is a lot of promise for future. So to summarize, I showed you some examples of the significant improvements we have in blood cancers, not only leukemia, lymphoma, but also others we have heard about. And there is no question that the new treatments are targeting cancers in many different ways, whether it is the proteins on the surface of the cancer cell, whether it's a pathway that the cancer cell is depending on, and just what I told you in the last slide, even the environment in which the cancer cell will be thriving. So those are all targets for these new agents. And finally, of course, I would encourage everyone, whenever there's an option, to participate in clinical trials, and that is the only way we can make progress. And not only your participation, but also participation of agencies like Leukemia Research Foundation, which over the years and decades have helped fund these trials to make these things happen. Thank you for your attention.